again to Prof. Richard Barr. He will give us a talk about current trend of breast elastography and guidelines. So please.
Thank you. So, I'm going to go kind of fast in the first part. We've been doing breast elastography for about 20 years. So I'd like to go over the principles and discuss how elastography can be used to characterize breast lesions. And since we've been doing this, we had a marked increase in the amount of positive breast biopsies because we're decreasing the number of not doing biopsies of benign lesions, learn how to perform strain elastography and shear wave elastography, and describe how to incorporate elastography into clinical practice. So palpation has been used for thousands of years to evaluate the human body, and really elastography is now an extension of us doing a physical exam to determine if something is hard or soft. We've got V-mode imaging that gives us anatomy, Doppler that gives us vascular flow, and we now have elastography that gives us tissue stiffness. So why would we want to use elastography in breast? Krupsik in 1998 looked at in vitro specimens and found that for breast lesions, there was a huge difference between stiffness and there was very little overlap between benign and malignant. For other organs, there were similar findings, but there was a lot more overlap. So theoretically, breast elastography should give us the best results. And again, we have strain elastography, where the stiffness is calculated based on the displacement of tissue from compressive force, which is qualitative. And we've got shear wave elastography, where we use that RV push pulse to generate the shear waves, which we can measure the speed of the shear waves, and that calculates the stiffness value, which is quantitative. I'm going to skip that. This is my physics lecture for strain. So all that strain is we've got jello with an almond, and when we're going to apply our force here with a spoon, the almond does not change shape, so it's stiff. The jello changes shape, so it's soft. And this is all that the systems do. They look at the frame-to-frame differences of the tissues. If they do not change very much, you consider them stiff. If they change a lot, you consider them soft. So very simple. And then, again, what it does is it generates its own scale for each image that you do. So here we've got 5 pieces of tissue. When we apply the force, this one has the least change. So it's going to color code it black, because I'm going to choose black as the stiffest. Then it finds the area that it has changed the most. It's going to call that white, because that's the softest. Then it's going to place the other tissues as shades of gray in between there. So it's a very, really simple concept. The key here is that it's giving us relative stiffness. So we can not know exactly how stiff something is, but we can say if it's stiffer or softer than the adjacent tissues. So this limits our use. We can't use this for screening. And again, the optimal technique is different for each manufacturer. So on the Mindray system, you don't have to do anything. You don't have to move up and down. It's a very sensitive system. Just the patient's breathing will give you the stress that you need to do this. So it's very, very simple to do. I like to use black for breast. Black is stiff and white is soft. You can use color maps. There are many available. So the technique is what we try to do is we try to rotate the patient so that the probe is perpendicular to the floor. And when the patient's breathing, the lesion is moving up and down in our plane. So usually if the lesion is medial, we just leave them in the supine position. If it's in the outer quadrants, we usually rotate them up on their side so we can do this. And again, really it's just the patient motion is going to give us all that we need. So again, what we want to do is when the patient's breathing, we want the lesion to stay in the plane. We don't want it to go in and out of the plane, because if it goes in and out of the plane, it may look smaller or bigger and therefore give us inaccurate results. So we always want to keep the field of view as large as possible, and again, because it's relative technique, we want to include fat, normal tissue in the lesion. So normally fat will always be the softest that you have. If the lesion is benign, it's usually about the same as normal breast tissue. So those will be the stiffest areas. If the lesion is a cancer, it will be black and the normal tissue will be gray. And again, what you want to do is compare the lesion stiffness to other tissues, and you can always look at the B-mode image to determine the amount of displacement. So for breast imaging, the most critical part is something called pre-compression or preload. So with the liver between the ribs, no matter how hard you push, you are not compressing the liver. But with the breast, which is on top of the ribs, as you compress, you're changing the stiffness of the breast by adding pressure. So what you want to do is you want to use light touch or very, very minimal touch on the transducer because it will change the measurements. So this is what we published in 2012 when we did shear wave measurements on all different kinds of breast tissue, and we'll display what this percentage compression is. But basically about here is where we do a mammogram. So you can see as we compress the tissue with the transducer, all tissues, even cancers, get stiffer. So actually when we get to the point where we're almost like a mammogram, that is as stiff as a cancer. So we want to be doing all our measurements down here where we have the most difference between all the tissues. So the way we do this, and again, this is how I've gotten the lab to everybody do the same thing. What we do is as we find our lesion and we do our standard exam, then we're ready to do the elastography, we look at something. So in this case, here's a rib. It could be, it could be a Cooper's ligament, it could be anything, but we always apply pressure when we do B-mode imaging because it flattens the Cooper's ligament so you have less artifacts. So then when you're ready to do your elastography, you start lifting up the probe. And as you lift up the probe, you look at something and you'll notice that it'll get farther, deeper and deeper in the image. And when you get it as deep in the image as you can, and still have contact, that's when we do our elastography. So in this case, when we did our B-mode imaging, this rib was at 3 centimeters. When I lifted up the probe, it went to 4 centimeters. So I consider that a 25% compression that we're applying here. So again, this is a nice technique that everyone can use and everyone can do exactly the same technique. For strain elastography, when we do this, if you apply too much compression, you'll only get noise. If you are in a mild compression, what you may notice is you'll see a good image, then bad images, good images, then bad images. But if you apply minimal compression, you should have relatively uniform strain images throughout the cine loop. When we look at shear wave, these are those curves again. You can see that the peaks have all shifted to the left. That's because the lesion is stiffer, and it's easier to see that on images. So here is a simple cyst, and as I apply pressure, you can see I turned it into stiff enough to be a cancer. And again, if you look closely, here's the rib, and you can see that the rib was up here, and as I lift up the probe, I release the pressure. So it's very important, again, that you apply minimal pressure. And you'll notice that, particularly in strain, it's almost like you want to lift the breast up with the probe. And even though strain is relative, there's a unique feature of breast cancers, or breast lesions with elastography, both strain and shear wave. The malignant lesions get larger on elastography and benign lesions get smaller. Why this happens, I don't know that anybody knows. We think some of it may be desmoplastic reaction in the cancers, but that doesn't explain why benign lesions get smaller. So we use what I call the distance ratio, elastography ratio divided by the B-mode ratio, and if that ratio is equal to or greater than 1, we consider it malignant, and if it's less than 1, we consider it benign. There are other methods, the 5-point color scale, which is kind of based on BI-RADS. 1, the lesion is entirely soft. 2, it's mixed, soft and hard. 3, it's stiff, but smaller than the normal B-mode image. 4, it's stiff and the same size as the B-mode image. And 5, it's stiff and larger than on the B-mode image. And in some systems, you get this blue, green, red artifact for cyst. You don't see that in the Mindray system. You see what's called the bullseye artifact that we can talk about at the break if you want. I did include it in the talk. But it's very specific for characterizing either cyst, but simple or complicated as benign. Another way of using elastography strain to get semi-quantitative measurements is you can do something called the strain ratio, where you put a cursor over the lesion and a cursor over fat. We're always going to use fat as the reference tissue, and the system will print out how much stiffer a lesion is than fat. And here it's 8.6, and I use 4.5 in our lab for the cutoff value for most systems. So we would consider this a cancer. So we have 3 different ways of doing this. So again, I prefer the length ratio, and we conducted a multi-international study some time ago, and these are the results of that study. So we had 635 patients, 222 were malignant, 413 were benign. If we look at the malignants, 5 of the 6 centers had 100% sensitivity by using this method. 1 center had 97%. And when we look at those 3 missed cases, they were DCIS and invasive lobular cancer, and it was probably that we didn't measure things correctly on the B-mode image because we couldn't see it well on the B-mode image. But 99% is pretty good, even if we consider those boo-boos. The specificity varied greatly between the sites, and this was before we really understood pre-compression, and I think pre-compression was part of the reason, but still 87% is a quite good specificity, and they raised up to 95%. If we look in the literature, I pulled out some of the major papers, number of patients, sensitivity and specificity, and which of the techniques they used. And you can see they're all in the high 80s or up to 100% sensitivity, and the specificity is the same, high 80s to the high 90s. So this paper was just accepted for publication, and it hopefully will be out shortly. We did a meta-analysis on all of the literature on strain elastography and regrouped them using the E to B diameter ratio, the 5-point color scale, and the strain ratio. And these were the sensitivity specificities. And you can see that the E to B ratio was the highest sensitivity and the highest specificity. If we look at what's really important here is the negative likelihood ratio, and 0.03. And what this means is that if you had a lesion with a pre-test probability of 50%, a BI-RADS 4B lesion, you could downgrade it to a BI-RADS 3. And you can't do that quite as much with the others. So we really like to use this E to B distance ratio because we think it's actually more sensitive. These are the ROI plots for the E to B, the 5-point, and the strain ratio. And actually this one outlier on the E to B used color. And I think it's real hard to measure things with color, so we don't use it. These all use black and white, and you can see that all these papers had quite high sensitivity and specificity. So if we go to shear wave, we talked about how to do this, and it's very similar to what we do with liver. You're just going to push the button, but again, you want to make sure that you don't have pushing pressure onto the breast lesion. We talked about point shear wave and 2D shear wave for liver. You really can't use point shear wave when you're looking at a focal mass because most cancers are very heterogeneous. And with the point shear wave, you don't see that large area with a color map to point out to you where the highest area is. So you're guessing with the point shear wave, so you can't really make an accurate measurement unless you do multiple measurements throughout the whole lesion to find where the stiffest area is. So we always recommend that you always use 2D shear wave. People say that there's an advantage to 2D shear wave because it's less operator dependent. I think that's probably true with the systems that you, for strain, have to apply pressure and learn where that sweet spot is. But again, on the Mindray system, you really don't have to move the transducer. You just lift up the transducer and the patient's breathing will give you the result. So the learning curve is actually quite low. And in both shear wave and strain, the biggest problem is pre-compression. That I think people don't realize how hard they're pushing with the transducer. So here's just a case, obviously a BI-RADS 5 spiculated mass with some desmoplastic reaction and calcifications. It has some internal blood flow. Here you can see on the strain elastogram, the lesion gets much larger. And we've had lesions get 3 times larger than on the B-mode image. On the shear wave, you can see, what's interesting is a very common finding is that the cancer itself actually codes as very soft, but you often have areas of stiffness in the surrounding tissue. We'll describe this in a little bit more detail shortly, but what we want to do is we want to find either in the lesion or in the surrounding 2 to 3 millimeters where the highest stiffness is to use. So here, this is an artifact. Even though this is coding this is very soft, in reality it's very stiff. A benign lesion, and here's the bullseye artifact. It's a white dot surrounded by a black area and a distal white dot. And again, we published this with another machine, but what I've learned so far on this machine is very much the same, that we have 100% sensitivity and 100% specificity for using this sign to characterizing a lesion as a benign cyst. If there is a component that's solid within this lesion, it'll show up as a defect. You'll see a stiff area, so then that will tell you that it's not a complicated cyst, but a complicated cystic mass, and you need to do further work to decide if it's benign or malignant. On shear wave elastography, a very simple cyst without any echoes, a really anechoic cyst, will not color code because we need B mode to track it, and if there's anechoic, we don't see anything. So we can't get a signal that it won't be color coded. But most cysts have some complications or some internal debris, and they'll all code as very soft. So you won't be able to distinguish a fibroadenoma from a cyst with shear wave elastography. So again, the biggest problem with shear waves is this, what people have called blue cancers or soft cancers. So in our experience, about half of the invasive ductal cancers will code as soft or have no signal, but you may have that surrounding rim that will be the clue that they're malignant. And this is not a vendor problem. This happens on every system, and I think I've evaluated breast lesions in every system. And here's just an example of a malignant case that's malignant on all the strain images and is benign on all of the shear wave systems. So again, this is a problem based on the histology of the breast cancers. They're just very stiff and we can't generate shear waves. And we published this where again we looked at the curves coming out of the back of the machine, and in this blue area what we see is just noise, and the system interprets this noise as soft. And as we get to the periphery, we start getting these nice curves again. Even though there's some noise, it can calculate measurements, so we can use this. But in probably about 10 to 20% of patients, we don't get the rim. So you can actually get false negatives using this technique. So what we did is we worked with another vendor, and what we developed, here's the velocity map. It was a blue cancer. That is what we talked about in liver. Here it's green is go, yellow is caution, red is stop. And again, it looks at a lot of the quality of those shear waves and tells us where they're bad. And here you can see throughout the whole cancer, we've got very bad shear waves. So we shouldn't believe this data. And in fact, in our experience, if you've got a solid lesion and you've got this bad quality, those all turn out to be cancers. In that study that we did, again, strain was the best. Shear wave without the quality factor actually was the worst. But when we added the quality factor, anything that had bad quality, we considered a cancer. We've got sensitivities and specificities very similar to that we've seen with strain imaging. Comparing these for other things, again, depth, strain, it doesn't matter. As long as you get a beam mode image, you can do strain imaging. Shear wave imaging, we have the same problem that we talked about livers. The pulse attenuates, and usually after 3.5 to 4 centimeters, we don't have enough shear wave height to be actually to do a good measurement. Pre-compression affects both of these. In our experience, sensitivity is a cancer. We do better with strain. And the reason is that we can, with the blue cancers, in shear wave, that creates a problem. Specificity is a benign. We have a problem with strain. Benign lesions, fibroadenomas, fibrocystic disease are very similar to the stiffness of glandular tissue. So when we do the strain image, they just blend in, and we can't really do good measurements because we can't see the lesion. That's not a problem with shear wave because we don't have that problem. These lesions are not stiff enough that we have artifactual problems with the shear wave. So we like to use the combination of both of these, realizing those factors, and I think it's helped us increase our confidence and our accuracy in doing these. Obviously, strain is not quantitative and shear wave is, and we really like that bullseye artifact. And again, if you want, we can talk about it later, but we use that a lot to not do biopsies. If we get the bullseye artifact, we consider it benign. This is from the Wolfram Guidelines that's now several years old. This is the 5-point color scale, and we did it in both blue is hard, red is soft, black is hard, white is soft, red is hard, and blue is soft. If we look at the E to B mode ratio, and again, we kind of did this on a BI-RAD scale, anyone that had a length ratio of less than 1, we considered it 2. If the E to B ratio was 1, we considered it a 4. And if the ratio was greater than 1, we considered it a 5. If we look at the strain ratio in the literature, all the papers have a less than 2.8 as benign, so we gave that a 2. All the papers had a ratio greater than 4.5 as a 5, or cancer, so we gave that a 5. And then there was a lot of variability in these, so we kind of mixed that group in the middle and called it 3-4. If we look at the shear waves, all of the papers that had a 20 kPa or less were benign, so we gave that a 2. All the papers that had a 80 kPa or higher were malignant, we gave that a 5. Then in the literature, if you look at a lot of papers between 20 and 60, we gave that a 3. More papers considered that as malignant, so between 60 and 80, we gave that a 4. And again, part of this is vendor variability, particularly in the strain ratio. So you can improve this based on using one system. So again, very light touch. And again, it's almost like you're lifting up the transducer. You're almost wanting to pull the breast up. A lot of coupling gel when you do the elastography. You're going to hold the transducer still. And again, position the patient so that the breathing moves the lesion up and down in the image plane. We usually save a short cine clip and then go back and find the best image to do our measurements. And you can do strain imaging on any of the probes, the 20, the 14, the 11, or the 9. For the shear wave, again, the technique is very similar. Light touch, hold the transducer still and do a cine clip. However, again, the lower the frequency of the transducer, the stronger the RV pulse. So we recommend you use the 9 megahertz probe if you're doing shear wave of the breast. Because with the 11 and the 14, the RV's pulses are not strong enough and you may not get good measurements. So again, here's this invasive cancer, and here's the benign lesion. And again, using the color coding is very helpful on shear wave. And here we can see it's benign, and again, you can put an ROI. So this is the difference in the same lesion using the different probes. So here with the 9, you can see we've got good measurements throughout the lesion down to almost 4 centimeters. But when we go to the 14, you can see what happens. At this point, we really don't have enough shear waves to get good, or strong enough RV pulse to get good shear waves. So you got to be careful with that. And like I said, I think using the 9 is going to give you more consistent results. The system also allows you to have what's called the rim feature. If you wanted to, you could put an inner circle over the cancer, and then you can decide the size of the rim, 1, 2, or up to 3 millimeters, and you can get measurements from each of those. In our practice, I just put one ROI over the area that I see visually is the highest on the 2D map. So what are the cutoff values? So again, for strain, I like to use an E to B ratio of less than 1 and equal to or greater than 1 is malignant. Less aggressive cancers like DCIS and mucinous cancers can have a ratio of 1. So we include those. It kind of decreases our specificity, but we don't want to have any false negatives. We can use the 5-point color scale, and a score of 1, 2, or 3 is considered benign, 4 and 5 is considered malignant. And for strain ratio, using the FAT cutoff, a ratio of about 4.5. And for shear wave, we use a 4.5 meters per second or 60 kilopascals. We have not done a large number of patients, but the ones we've done have matched other systems. So I believe this is an adequate cutoff, and we're working on generating a large study to confirm that. So where can we use elastography? So we can say, is the lesion benign or malignant? And again, we can use those 3 methods. Or we can look at, is the lesion soft or hard? So is the lesion a fat lobule? So if you see a hypoechoic lesion in a glandular area and you're not sure it's a fat lobule, you can turn on elastography and you can confirm it's fat because it'll be clearly very soft. If you feel something and you don't see anything on B mode, maybe an isoechoic lesion, so it's very helpful to turn on elastography. And we often find lesions that we don't see on B mode imaging. So it's, I think, important, particularly if you feel a lesion, to do elastography to confirm there's no lesion. And again, now that we have the bullseye artifact, there's a lot of complicated cysts that are isoechoic. And another key thing is to define better where to biopsy. And I'll show you a case that highlights that. And the stiffest area is going to give you your best radiology pathology correlation. And as we're getting better and better with this, we're starting to characterize lesions and have some pathognomonic things. So some more examples. Relatively well circumscribed, very heterogeneous, partially cystic and complex lesion. Has some internal blood flow, but it's markedly larger on elastography. I didn't actually do the measurement, but it probably has a ratio of 2. And here on elastography, again, you can see that the central portion of the lesion actually shows up as soft, which in reality is very stiff, but we have this big high velocity rim that was 163 kilopascal, so very in the malignant range. And that was an invasive ductal cancer. So this is the case that I've learned the most from. It was an elderly patient that had a new lesion on mammography. On ultrasound, the lesion was isoechoic, and I kind of say it had a head that I circled in red, a body, and a tail that I put the green arrow on. When we do our elastography, the head disappeared. The body and the tail got larger, so we biopsied this lesion, and it was an invasive ductal cancer. So when she had her lumpectomy, I went with the pathologist to look at the specimen, and it turns out this was a fibroadenoma that was attached to the cancer. And we've now seen many of these, so it's not uncommon for us, what we thought was one lesion on B mode actually is 2 lesions that we can identify on elastography. And you can see that if we had biopsied here, we would have gotten a fibroadenoma. So again, we like to use elastography to find the stiffest area to make sure that we're getting the best pathology. This is a mucinous cancer. It has a ratio of 1. I show this for a couple reasons. Number one, it's not that obvious on B mode image, but it's very obvious on elastography. So that's not an uncommon problem. And like I said, the reverse is also true with benign lesions in glandular tissue, that you may not see it very well on elastography, but see it really well on B mode imaging. And then this, we looked at several hundred cases of the diameter or the distance ratio, and here you can see the ratios. And again, the mucinous cancers and DCISs had ratios down to 1. As we got into the more invasive ductal cancers, the ratio increased, and we've had ratios of up to 3 or even greater. And again, this is the problem with strain, is benign lesions. This is one of my mistakes from the multi-center trial. Here it turns out to be this lobular hypoechoic mass. In red, I'm surrounded by glandular tissue, which is the green dots. And when I interpreted this, I said, oh, it got much larger. But in reality, what I was doing is the lesion blended in with the glandular tissue. And if we look closely, maybe this was the lesion here, and it actually was smaller. So it's very difficult to do. So now what I do is if you've got a hypoechoic lesion in dark, dense glandular tissue, if you can't find the lesion and it blends in, it's going to be benign. If you have a cancer, it's going to be easily identified, and the glandular tissue is going to be a light gray or white because the cancer is going to stand out. Just another example, well-circumscribed mass, some internal blood flow. The ratio here is 0.96. And again, a KPA of 45, which is kind of at the borderline. And this turned out to be a benign fibroadenoma. So how do I interpret the images? And again, I like to use both strain and shear wave because I think strain is higher sensitivity, shear wave is higher specificity. So both the shear wave and the strain are suggestive of a benign lesion. I have high confidence it's a benign lesion. Our only false negatives have been lymphoma. So if I see a well-circumscribed, very hypoechoic lesion with marked internal blood flow, particularly if the patient has lymphoma, we go ahead and biopsy it. If both the shear wave and the strain are suggestive of a malignant lesion, we have high confidence the lesion is malignant. And our false positives are mastitis, and partly because it's the inflammation, we don't see well on B mode, but it increases the stiffness, so it shows up on the elastography. So the other one is fat necrosis, that again, some inflammation around that makes the lesion very stiff. And we've had a few fibroadenomas, usually in younger women that are hormonally stimulated, they may be a little bit stiffer. So clinically, if the patient has mastitis, we would ask the referring doctor to treat them and then do a short-term follow-up to make sure it goes back to normal. And if we see calcification suggestive of fat necrosis on mammography in these patients, then we would also do short-term interval follow-up instead of biopsy. If strain is positive and shear wave is negative, again, we check the quality of the measurement on shear waves, and if it's poor quality, we consider it malignant. And in general, all these lesions will be biopsied. If the strain is negative and the shear wave is positive, consider that you added extra pressure when you are performing the shear wave. And one way of doing that is checking the stiffness of fat. So the stiffness of fat should be about 1.2 meters per second. If it's 3, you know you've applied so much pressure that you're getting a bad measurement and you need to repeat that. If the shear wave is still suggestive of a malignant lesion, we biopsy it, and obviously if it's a 4B, 4C, or 5 lesion, we would biopsy it. So both strain and shear wave provide additional clinical information on breast lesion characterization. Technique is critical, and it's always done in conjunction with B mode. At least in our hands, using strain, using the distance ratio, has the highest sensitivity, and shear wave has the highest specificity. And again, we've seen significant improvement in the sensitivity of shear wave now that we've added the quality measure. And again, I think the combination will increase your confidence and accuracy. Thank you. Questions?
No questions? We can accommodate some questions.
Thank you very much, Prof.
In this section, I will take the pleasure to chair in a little bit because the next speaker will be Dr. Nadia. Dr. Nadia is a consultant in women imaging ischemistry and also director of